So, what do you think? Should we start, Davide? Yes.
Yeah, let's start.
Okay. So, hi everyone. Actually, good night in Thailand, and good morning in America. And what else? Where you guys come from? What time is it in Croatia? I don't know. But anyway, hello to everyone from us. We are a WinFocus panelists, and today we have an exciting webinar. We have Brett Nelson, that actually one of the best lecturer in PoCUS in the world that I know. This is not overrated. We have Anthony Dean, who is actually emergency physician from Pennsylvania, here joining us as the director of this movie, and we have Davide from WinFocus Secretariat, because Davide is Italy, so that's how they pronounce it. And me, I'm from Thailand. I'm Sudapal from ER, July or emergency room, Chulalongkorn. And we have Gabriel also. Gabriel is hiding his face because he's on vacation. They have a nice view. There you go. Hi, Gabriel. Everyone in Thailand or in anywhere in the world probably know that Gabriel is one of the best who teach us about PoCUS in ECHO also. So today, getting right to the point, we have Brett that's gonna talk on the lecture that say on his last shift that he saved lives times money with PoCUS, not in that order, but So hello, Brett, how are you?
Hello, welcome. Thank you all so much for having me. Thank you to everyone around the world who is logged in here. 82 people. We'll spend the next 45 minutes or an hour together. I'm really honored by your presence, and I'm honored to take part on this panel. What I'd like you guys to do, and some folks are already doing this, is please keep the chat active, and please keep the questions active. I'm just going to talk about a couple of really simple, as I would say in English, bread and butter ways, really easy things that you can use ultrasound for. So for some people, some of these applications might be a bit basic, but I want to talk about how basic things can make a big difference for patients. I want to talk about making ultrasound accessible to all providers. So not just the folks that are so interested in ultrasound that they live and breathe ultrasound every day on every shift, but how do we get the rest of our faculty to use them? And I think sometimes seeing really simple cases and really simple uses for ultrasound can bring people to using ultrasound that hadn't previously done so. I am an emergency medicine physician. I work in New York City, and we see all different kinds of cases, and you'll see a little bit of a variety of the kinds of cases that we see here, from the very complex to the very simple. And we try, as much as I love ultrasound because it either saves time or money, or it improves the care of patients. So I'll be the first person to say to not use ultrasound when it's not going to make a difference. So I just happen to think it makes a difference pretty frequently, but it doesn't mean that I scan every patient, and it doesn't mean I spend too much time doing it, because that defeats the purpose. So, so you guys know where the chat button is. Hopefully you know where the Q&A button is, and I can get started showing some slides if that sounds good.
Okay, great. So everyone, again, let's make this a very interactive session. So you can type in anything that you wonder, whether you are a resident, emergency physician, or you are ICU fellow, as I can see somebody applied. Please type in as many questions as you wish, and Brett or I will answer live. We will not answer with chat. Don't worry, we will answer with our we'll answer you directly. So please type in anything that you wonder about the case, or about anything that's relevant to the case that you think that it would help you. So please, Brett, go ahead.
Okay, great. And Sudapon, as I'm sure you know, when I'm sharing my screen, I can't really see anything else. So if there are questions, please just jump in and interrupt me, because there are 82 people on this call. You outnumber me 82 to 1. So what you have to ask is more important than what I have to say, right? So please, please field your, don't be shy about your questions. Thank you very much. Okay, so once again,
Yes.
I am Brett Nelson. I'm a professor of emergency medicine at the Icahn School of Medicine at Mount Sinai in New York, and I am on Twitter at Brett P. Nelson. And that's a great way to reach me for questions and any other contact moving forward. Certainly today you have the chat function and the Q&A function, but how are you going to find me tomorrow? Well, I'll be on Twitter. So let's just jump right in. So one of my colleagues called me because there was a 48-year-old man who had triggered our sepsis protocol. He was immune compromised. He had a fever. He was tachycardic. And a few nurses had tried to stick this poor gentleman. He had no veins. One of the docs had tried. So they called me over because they heard that I was awesome at putting in IVs. So I took the ultrasound machine and brought it over to the patient and looked up and down the arm and was able to find this very compressible structure on his upper arm, and then following it up a little bit further, made sure that it wasn't near any nerves, and that it wasn't pulsating. And here we can see that I was tracking in. Can you guys see the cursor on my screen by any chance?
I saw it. I see it. So
okay.
yes.
Yeah. So right
Yes.
up in this location here, we can see that I actually, have the needle in the vein and was actually able to visualize that pretty well. So, this is probably, it's going to sound maybe very basic, but in this case, we were cannulating the basilic vein, but, using ultrasound to guide venous access is probably the most common procedure in my emergency department. And it's as simple as that. Probably every resident, every doctor is doing this several times per shift. We have patients who have cancer. We have patients who have immune compromise. We have patients who are on dialysis. Some patients that use intravenous drugs. We have all kinds of reasons. Certainly patients that are dehydrated and sick and septic, like this gentleman was. So we have so many patients who are who have poor venous access, and whenever they go to receive care in a hospital environment, they're getting stuck over and over and over again. And I'll tell you that 10 or 15 years ago, we would have patients that say, I'm a tough stick. It's very difficult to get a vein on me. No one is allowed to touch me except for Nurse Mary on the 9th floor on the oncology unit. That's it. She's the only one. Call her, she'll come down. And it was based on, a particular person, usually a nurse that had worked for a long time with a lot of experience. Now, today, patients come in and they say, I have very bad veins. No one is allowed to touch me unless they use ultrasound. And the patient doesn't really care who's using the ultrasound, but the technology has in a way replaced some of the experience. So this opens up a whole world for people, and it's much easier and it's much faster for patients. It's also very rewarding for nurses to have a new tool in their toolbox. So we can set this up as a 2-person technique, like we see on the left here. We can set it up as a 1-person technique, as we can see on the right. You would approach the patient the exact same way you normally would. You face the patient, you have the needle in your dominant hand, but you now have a probe in your non-dominant hand. And here you can actually see we have a long view looking at the vein, and we can see the needle just starting to come into the vein, and we can follow it in. And here, just one last point I'd like to make about this. If you're starting to use ultrasound to guide venous access, you're probably going to be putting the needles into veins that are a little bit deeper than you normally would, deeper than you could see, deeper than you can feel. So you have to make sure that the catheter is long enough. So when the catheter is in the vein, for it to be stable, you need 1/3 of the length of the catheter to get you to the vein, and 2/3 of the length of the catheter to remain inside the vein for it to be stable. So I'll let you all do the math, but the point is that the catheter needs to be long enough, not just to reach the vein, but to be able to get into the vein, stay in the vein, and be able to tolerate the patient moving their arm around, shifting around in the bed, etc. So it's really one important thing to think about. If you're using this technique, throw it up into the chat. If you are, if your nurses are using this, please put that into the chat. In my environment, we have our physician assistants and our nurses, as well as the doctors using this technique. And as I mentioned, it's a very empowering thing for the nurses to be able to use ultrasound, because they're using a lot of different techniques to get difficult venous access to begin with. So, do we have any questions or comments on this?
Not yet, but I'll ask questions.
Yeah.
So basically, I was wondering if, so which axis do you normally use? Long axis or short axis?
So which access, so you mean which approach do I use? Yeah, which approach do I use? So I personally really like to use the short axis approach, which is also known as the as the out of plane approach. And what this means is I'm holding the ultrasound beam in this plane, and the needle is coming in like this. That's referred to as an out of plane or a short axis approach. A lot of people like a long axis approach where the beam is parallel to the needle coming in. What I like about the short axis approach is that I can see left and right. I can see, and this is an example of the video was a short axis approach. I can see that to the right of the screen here, to the right of that vein, there's a nerve. And I can see that a little bit deep to that vein and further in, there was an artery. When you're in the long axis, you don't get to see all the other surrounding anatomy. So I really like that. And I like that if I put the needle in and I see it to the right of the vein on my screen, I know that I'm too far to the right and I can adjust that. I find it more challenging to line up the probe with the needle and the vein all lined up in the same plane. I find that more challenging.
Okay, let me stop you right there. There's a little bit of technical issues. So we saw a little bit of gray box. So could you try to, let's stop the screen sharing and try to do it again? I don't know if it's help. And then Gabriel suggests that, so when you share the screen, let's try to stop your video also. So let's try to just share the screen.
Okay, so just share the screen of my presentation. All right, I apologize to anyone who's having issues. So you can see my screen now?
Yeah, it's clearer actually.
Okay.
So it's, there's no gray box, great.
Okay. Fantastic.
And so, there you go. There's some great, there's good. We have some answer. So Dr. Patharapong says that, hold on, where is it? He said that he used long axis approach. It's easier for him to start. So that's the answer from Thailand, actually.
Yes, Thailand has spoken.
Yes.
No, both techniques are wonderful. I mean, look, I'm showing a slide right now that shows a gorgeous catheter in the vein, and I can see how much catheter is in there and how long the catheter needs to be. There's really great benefits to both approaches. And I think if I think the short axis might be easier for some novices when you're first starting out. And I think when people get more experience, a lot of folks like to use the long axis approach, which is what's pictured here. The reality is that I probably switch back and forth between the two approaches depending on the exact patient. For example, I was putting in a catheter on a patient who had, who was a very obese person, had a lot of subcutaneous tissue, probably 3 or 4 centimeters down to this patient's basilic vein. And I would, in the short axis, I would find the needle right on top of the vein, and I just so because it would just bounce on top of the vein and it wouldn't puncture it. And only when I was in the long axis, I could appreciate that I needed to change my angle a little bit to better get into that vein. And that patient said, I'm going to get stuck 20 times. I just know how it is. So the nurse called me over, and I placed a longer line into this patient. I don't always do this. In fact, it's rare that I check on a patient in the hospital itself, I think because I'm so used to being in the emergency department. But I went to visit him a day or two later in the hospital, and he said, I have never been in the hospital where I only got stuck once. I saw you 2 days ago. You put an IV in me, and every blood draw and every medication and everything I've needed since then has been through this IV. That was awesome, you know, and because this is a guy who would get stuck 5 to 10 times every day, every time he came into the hospital. And what a miserable experience that is. You know, we don't even think about these things because for us as the doctors, it's just a part of our workflow. We need labs, we need to give a medication. Think about from a patient's perspective that they're getting stabbed with needles. You know, we're so used to it as people who work in a hospital environment that we don't think about it. We have to remind ourselves the average person does not get jabbed with needles 10 times a day. That's just not a thing that happens to them. So if we can limit this for patients, it's very helpful. All right, so I'm going to move on.
I dropped off the internet there for a moment. Brett, did you address, if you're in the transverse approach, the off-plane approach, the concept of following the needle tip? Did you mention? Did you talk about that?
I did not talk about that. What I was talking about was that people don't like to get stuck multiple times with needles, but your thing's important too. So we also, so when you are tracking, can you guys see my hand? Because I can't see myself here.
I can see your hand.
Okay,
Yes,
so you have the plane of the ultrasound beam, and the needle is coming in towards it. If you don't move the ultrasound beam, then the needle goes past it, and you no longer know where the tip is. The tip is someplace off the beam. You can't tell. So you have to, as soon as the tip shows up on your beam, you have to move out, and then you lose the tip, and then you move the beam. You move the needle in again. And then you move the probe away from yourself and you follow the needle tip as you go. And that's really very important because as you insert the needle into the patient, you want to know where the tip is. The elegance of that long axis view is when you have the beam in this direction, you can see the needle tip the entire time. And that's great. If you're going to use a short axis or an out of plane approach, you need to be moving the plane to follow the needle tip as you go in to make sure that you have an accurate impression of where that needle tip is.
Okay, so Brett, we have 2 questions. First, we go back to Farah first. Hi, Farah. So Farah said he couldn't see your hand. So you have to do the thing again.
I have to do the thing again.
Yeah, you have to do it again.
Okay. How's now?
Yes, now it's better.
Okay. So this is the ultrasound beam. I don't yet see my needle. I start to put the needle into the patient. Now, as soon as the needle touches the beam, I can see it. And as soon as I can see the needle, I need to move the beam away a little bit. And then the needle disappears. And then I move the needle in and it reappears. Needle probe away, it disappears. Needle in, it reappears. So you track in bit by bit to follow the tip of the needle, and that's the key way that you follow the tip of the needle on the ultrasound.
So it's if you want to search more information, it's called dynamic ultrasound approach, dynamic needle guidance. Yes, Brett?
Yes.
I think it's called
dynamic needle guidance. Yes.
Yes. So another question from Dr. Chatgao. So she asked, after you see the tip of the needle, do you need to insert the needle deeper and slide the probe to follow your vessel at the same time? So it's a thing that we addressed, yes?
Yes, we do. We are always going to be moving the needle. I'll stop the share for a second. So as soon as the needle hits the beam, we move the beam, move the needle, move the beam, move the needle. Now, what's coming out down here is the vein. So you'll see the needle tip getting closer and closer and closer to the vein. And then once you're on top of the vein, you pop through and slide the catheter in. And that's the way that you would guide it. That's the way that you would guide it through. Yeah.
I had one other comment, just to echo what you said about getting enough of the cannula inside the vein for a stable cannulation.
Yes.
We did research on the longevity of veins with various forms of cannulation, and it was definitely contingent on how quickly the cannula would fall out of the vein if it was too deep, if the vein was too deep. So one of the things that we came up with, and I don't know if you recommend this or have experience with it, is we've been using midlines, which is one of the forms of cannula that's 3.5 inches long. And actually in the United States, I don't know about in other places, but they're licensed to be left in for up to 30 days if they're inserted with proper sterile technique. So going along with the patient that you saw who'd never not been stuck 10 times a day, I think one of the things that we can do, but using this is to find a deeper vein, but also have a very high quality cannulation that is stable for the patient for several days or even weeks of hospitalization. And I don't know if you'd speak to the use of these longer catheters, the 3.5-inch midline catheters.
Yeah, no, I think that they are incredibly useful. We don't happen to use them in my department, but I know a lot of departments where they use them, and they're very effective. If you can, especially spot a patient who is likely to be admitted, and this is a great example. The case that I discussed was a patient who is was septic and immune compromised. The likelihood that that patient was going to get admitted was nearly 100%. So if they could get a midline placed on arrival, that's incredibly helpful for them. It saves time, it saves money. There are even some patients at some hospitals where they could be discharged earlier. So a patient with cellulitis, for example, who needs intravenous antibiotics, if they have a midline placed in the emergency department, they could potentially be discharged with intravenous antibiotics and a visiting nurse, getting their treatment at home. So there's a lot of options for this, and there have been use models that have been shown that save the hospital an enormous amount of money, way more money than would be to spent on the program itself.
So Brett, from Dr. Shung Wong, tell me if I pronounce this wrong, Dr. Wong. So he asked, could you, with your hand again, could you please indicate where did you start to scan the arms? This is a nice slide, actually. So where did you start to scan in the arms from Dr. Wong?
Where do I start to scan in the arms? Okay.
Yes.
So I'm going to show you in my body in just a second, but there's I'm going to show you another picture.
This has become more interactive than we expect. So thank you guys.
No, but that's great. That's great.
We appreciate it so much. Yes.
Okay. Can you guys see here the picture of the brachial vein, basilic veins, cephalic veins?
Yes.
Okay.
Clear.
So typically in the emergency department, we're going to be looking in the forearm and in the antecubital fossa. So the median antecubital vein, which would be labeled D here, or a little bit distal to that. A lot of folks in the venous access community, meaning doctors and nurses who spend all day in the hospital putting in intravenous lines, working in the line service around the hospital, they like to stay in the forearm region and leave the antecubital fossa alone. And I think a lot of that is because they work with many patients who will go on to have dialysis, or they again are difficult venous access patients, and they want to leave those larger veins alone, and they want to leave veins that are closer to arteries alone. So I try to use ultrasound to put it in the same exact location that I would put it even without ultrasound. So if I find a vein in the forearm, I might use it. If I find a vein in the antecubital fossa, I'll use it. And then if I don't see anything, I'll go further up the arm and I'll look around the brachial vein or the basilic vein. But I don't stick it there yet. So in other words, if I don't see anything in the forearm and I don't see anything in the antecubital fossa, I'll look up in the upper arm. And If I find a vein there, I'll then try to trace that vein down more distal. And sometimes I can't see anything in the antecubital fossa, but if I see the vein higher up in the arm, I can then follow it back down to the antecubital fossa, and I'll still get a more peripheral line that way. And I like to try to do that. So it's really only if I can't find anything anywhere else that I'll place the catheter, hopefully in the basilic vein, because it tends to be large and it tends to be, and there's no nerve or artery near it. And if I'm really stuck, I'll probably use one of the brachial veins. And I don't like them as much because they're often buried next to a nerve, and they're also right next to the brachial artery. So I try to avoid those when I can. So that's, again, how I approach it. I try to go wherever I normally would go for regular venous access.
Okay. Another question, Dr. Piesat. How long would it be? I mean, which size, or I think Anthony just said 3.5 centimeters, but I don't think we have that.
Right.
Normally,
So,
which size of medicut or needle that you use?
Yeah. So
our midline, actually, just to jump in, a midline in the States is 3.5 inches, which actually is more like nine centimeters. But I'll let Brett answer the question.
Okay.
Yeah,
Thank you, Anthony.
You're right.
Yes.
It's pretty long.
Thank you very much.
So, so what you asked, whether you know it or not, you asked me a math question, and I like to respond to math questions by avoiding them, and I'm going to avoid it by showing you a picture while I talk a little bit. So you see the longer and the shorter catheters here. So the shorter catheters here are, and I apologize for being American, that I'm going to say inches, but they're about an inch or an inch and a quarter. So what is that? Maybe 3 centimeters or so at most. So these shorter catheters are the standard catheter size. And you see here, there's a variety of longer sized catheters, and even one really long catheter, that the orange one on the bottom right is again that 3¼ inch, which I guess would be 9 centimeters. Thank you, Anthony, for the math. So the idea is that I'm usually using catheters that are somewhere around 2 inches to 3 inches long. So where do I get those? The same company that makes the normal intravenous catheters that they sell to your department also sells the longer catheters, and they're actually usually not much different in terms of their cost. So I think it's very helpful to have some of those longer catheters around. If you don't have them in your department, you do have them in your department. You just maybe haven't thought to look in these locations. One location is a radial arterial line kit or a femoral arterial line kit. In an emergency, could be used. They have flexible catheters. They usually have a guide wire that will even make it easier to place the catheter. They're single lumen. They tend to be about 18 gauge. And you can sometimes use that to get into a longer, or a deeper vessel. Also, in your central line kit, there's a long angiocatheter. And we don't often use it when we place the central line. Some people wonder why it's even there. But there's a long, usually again, an 18 or a 20 gauge angiocatheter in that central line kit. So even in a department that doesn't really have longer IV access lines, you do have them in your A-line kits and your central line kits. And otherwise, it's just worth speaking to whoever orders your normal lines to get those longer ones. It's very helpful to have those around. So.
I think we don't have any more questions.
Okay,
so
yeah, I was just going to suggest
yes.
This is amazing. I love this. And let's just go on to some more cases and see how this goes.
Okay.
So
I think we have the gray screen again.
Okay.
I think you'd have to close and share again.
Yeah. Okay, can you all see the next case, a 9-year-old?
We still now we have black screen actually.
Oh, a black screen. I don't know if that's progress or not. I'm going to.
Okay. Now it's better. Now it's
Okay.
better.
Okay.
Okay. Let's do it.
Okay. So a 9-year-old male comes in. He has fever, chills, and cough. And his lung examination with the stethoscope sounded very clear. The doctor was concerned, though, that he could have a pneumonia. And especially since there were other children in the house, he wanted to make sure that there was that they would be treating pneumonia if there was one. So we can see here the skin and subcutaneous tissue on the top of the screen, the lung sliding back and forth. We can see the liver on the bottom right of the screen and the lung on the bottom left of the screen. And what we see here is a small amount of pleural effusion. There's also there's 2 rib shadows coming down, right? One right in the center of the screen and one to the left of the screen. So just deep to the rib shadows, we can see that instead of the lung appearing as just a bright white line of just pleura sliding back and forth, we can see that there's actually what looks like tissue down there. And it's above the diaphragm. The diaphragm's right in the center of the screen. It goes from just left of the rib to just under the rib as the patient's breathing in and out. And we see that the lung tissue has begun to take on a bit of an appearance of a solid organ. We call this hepatization, where the lung starts to look like liver. And we can see that there's an interruption in the pleural line and that there are some ring down artifacts coming down from that area as well. So, so this is highly specific for a pneumonia. And this is a very useful tool in a lot of different ways. Several of the folks who are on this international consensus panel, like Anthony Dean, Gabriel Villa, are on this call right now. And they determined through best evidence years ago that lung ultrasound is useful to rule in pneumonia. It's not as useful to rule it out, although some studies since the time of this writing suggest that the negative predictive value is actually better than we thought on some of the initial studies. And lung ultrasound is just as accurate as chest X-ray in children. And there have been several studies looking at this, including one by my colleague and another WinFocus member, Jim Sung, who demonstrated in an article that was published in Chest a few years ago that using lung ultrasound prospectively reduced the need for chest X-ray in children. So what a great example of how to make the diagnosis more accurate, how to make the diagnosis more quickly, how to save money and time, and to be able to do a full examination, including a radiological examination, meaning your point of care ultrasound on a patient while they're still hugging their parent and sitting in the bed. So, so we try to use this as often as we can. It also has implications that I think were discussed in previous webinars, you know, with COVID, with being able to clean the machine, being able to keep the probe covered and cleaned in a way that wouldn't be a vector for disease in a patient. It's very much more easy to clean an ultrasound probe and an ultrasound machine than it is to decontaminate a radiology suite, an X-ray machine. The provider who's caring for the patient, meaning the doctor, the nurse, whoever is already at the bedside examining the patient. So for them to take their existing contact with the patient and turn that into a more comprehensive evaluation using ultrasound doesn't put them at any additional risk. They're there already. Whereas having someone from radiology go from bedside to bedside and cleaning the equipment and doing examination after examination, you know, potentially puts them at increased risk. So there's so many considerations why we would think about using ultrasound of the lung, both in normal times and in COVID times. Any questions?
So we have questions.
Yes.
Yes, of course. We have from Dr. Nwanjan from Thailand. So I'm going to pronounce it like Miss Thailand, Miss Universe. So she asked, in pneumonia case, how many intercostal space should we examine for lung ultrasound? And
Right.
is blue protocol, is it useful or not?
Yeah. Oh, okay. So two different huge questions. I'll take the first pass, and then clearly, you know, since Dr. Villa and Dr. Dean are on this call, if they have any other thoughts on it, I would greatly appreciate their input as well. Depending on what you're looking for in the lung, you need to either look a little or you need to look a lot. For example, a young, healthy person who's laying flat and you're looking to see if they have a pneumothorax, you could really just look in the anterior lung on the left and the anterior lung on the right and get a very good negative predictive value and very good test characteristics to look for pneumothorax, because air is going to be up towards the ceiling, right? In contrast, when you're looking for lung consolidation, that can happen in almost any location in the lung where the lung interfaces with the pleura. So you really need to look comprehensively anterior, lateral, posterior, from the apex down to the costophrenic angle, from the apex down to the diaphragm, right? So what most people advocate is doing a sweep from the clavicle down past the nipple line, anterior, lateral, posterior, beneath the axillary line, and really imagine you're holding a paintbrush and you're painting the chest up and down. There are some authors that have also described that doing this in a transverse view in between the ribs as you go up and down is very helpful. So the protocol, for example, one simple protocol, there's many that have been described, that I know that Jim Sung used when he did his study looking at using ultrasound instead of chest x-ray, was looking at the midclavicular line down until the costal margin, the axillary line down to the costal margin, and the posterior chest down to the costal margin, and looking at each of those in a longitudinal and a transverse approach. So when you do that, you're looking at pretty much all the rib spaces. There's not much space in between those sweeps that you'd be missing, especially if you're looking at a child's chest. So the long story short, you really need to paint the whole chest with the ultrasound probe if you want to get the most accurate assessment, the highest sensitivity and specificity to look for pneumonia, because it can be a tiny consolidation and it really can be any place. So
basically, how many points do you scan practically? Four each?
So I usually scan
practically,
yeah,
like everyday use.
Yeah, so practical everyday use. I typically look anterior at the midclavicular line on both sides. That's 2, and mid-axillary line.
2 front.
Yeah, and then mid-axillary line, which is 2 axilla, and
2 sides.
And then I look on the right around the scapula and follow that down on the posterior side. So it's basically 3 sweeps on each side: anterior, lateral, and posterior on both sides. And if you sweep from the clavicle down to the diaphragm, you're hitting 6 or 8 intercostal spaces. So I don't think about it in terms of like I'm hitting 48 intercostal spaces. I just think about it sweeping from top to bottom in those 3 locations on both sides of the chest.
That's very, it's actually, sorry. It's actually a very pretty nice term, sweep. Very nice terminology, because normally we think about it as point, you know, like point 1, point 2, but this is actually where ultrasound become more advanced than stethoscope, because you can actually sweep up and down.
Yes,
so
exactly.
1, 2, great. And about Blue protocol, Anthony and Gabriel, any thoughts or any suggestion that we could use?
I think I'll let Gabriele answer that. It's definitely something that's more directed to adults. I just want to go back to this pediatric case. I think the evidence for looking for pneumonia is much stronger in children, and one of the reasons is because they have a much smaller thing to look at, which their lung volume is much smaller than adults. So you actually have a smaller area you need to scan. And secondly, their ribs are much less ossified, so that their shadowing is less prominent. So you can often see through the ribs, especially in children under the age of 2. Both of those are great advantages. One tip of the trade, which I think a lot of people overlook, is that when you're looking in the mid-scapular line, doing that sweep, basically from almost up, high up towards the shoulders down to the diaphragm, the way to get the scapula out of the way is having the mother or the child cross their arms in front of them, or even the adult if you're doing it on adults. So that brings the scapula away from that area that you're evaluating there. Finally, if you can, I think a lot of us are using a curvilinear probe for this because it has a bigger footprint and you actually get to see more. Or if in small children, the linear array probe with its high resolution is fine because the target is so close to you, that the pleura is close and the lungs are small. If you're doing that and you can go parallel with the ribs, it's a great advantage because you get to see a lot more as you sweep down. The only problem with that is that I think for less advanced people, having the ribs as a landmark to know where the pleura is a great help, because if you sweep down parallel with the ribs, as you go over the rib, you can get confused as to whether that's pleura you're looking at or actually the surface of the rib, because they both, in the normal case, they shadow somewhat similarly. So those are some of the tips of the trade that I would suggest. If Gabrielle is on the line to talk about the Blue Protocol or Brett, that would be great.
Oh, well, if you're calling me in, Anthony. So basically, well, the Blue Protocol was validated on a cohort of severe respiratory failure patients admitted to the ICU. And in fact, it does not entail even a complete exam of the entire lung. Once you find the findings you're searching for, it starts from anterior, then moves laterally, and only when nothing is found entails a scan of the posterior axillary line. So that tells you that the Blue Protocol is excellent, and it works where you're facing severe respiratory distress, and a patient who actually been in a severe condition will have the majority of its pathological findings presenting at the anterior surface. It could be acute pulmonary edema, it could be a massive pleural effusion, it could be pneumothorax, and only once that is not found, you will move laterally. So that speaks to an application which is actually particularly useful for patients in severe respiratory distress and severe conditions. If you're looking for a suspected pneumonia focus in a child or an adult with fever and not much of a respiratory distress, of course the exam must become more comprehensive as it has been described. So again, it depends on the clinical context, what works best. I hope that helps.
Thank you. I think we should move to, I don't think we have any more questions. Let's move to the next case.
Yeah, let's do that. Okay, so we had a patient who was a 54-year-old gentleman. He had end-stage renal disease. He missed dialysis for the last 4 days, so he came to the department short of breath. He was a bit tachypnic. He was tachycardic. He was hypoxic, and his blood pressure was borderline. He was, let's say, 95/60. And looking in his previous notes, the provider said, that's his normal blood pressure. He's sort of a thin guy, and he doesn't weigh very much, so he's always a little tachycardic. He's always a little tachypnic. But he described the treatment was dialysis, and the renal team took him very quickly. He came in the morning, and there was a slot available for him, so he was getting dialyzed in the emergency department, and we would think that would help him, right? He's fluid overloaded, just like all the other patients that get fluid overloaded when they miss their dialysis. So since he started getting chest discomfort and he was getting more short of breath during dialysis, we paused the dialysis and went over and we looked at his heart. So you guys are already being very vocal, which is fantastic, but I won't pause long enough to ask what you think is going on here, because I will tell you that one of our applicants to medical school, not even entering medical school yet, walked past the room, saw this ultrasound and said, wow, what is going on there? So this is as close to an ultrasound version of what we call a doorway diagnosis as possible. Here's another view of the same patient. This is an apical 4-chamber view, or what should be a 4-chamber view. One of the chambers is certainly not fully present throughout the entire cardiac cycle. So we discovered that this patient was in cardiac tamponade. Now, you almost can't have a lecture on cardiac ultrasound without somebody showing a tamponade picture. You know, it shows up every time you talk about cardiac arrest, and then there's a tamponade and you save the patient, or patient's short of breath, you find tamponade, you save the patient. I want to talk about this because this is a very insidious case of cardiac tamponade. This is the case of a patient who is chronically uremic, who long-term has some level of pericardial effusion, and who every few days goes up a couple of liters of fluid in their body and goes down a couple of liters of fluid in their body. So, you know, imagine the dramatic swings in preload that this patient has to deal with on a every 2 or 3 days basis. And perhaps one of the reasons that this patient was short of breath when they first came in was that they were fluid overloaded. And another piece of it, though, is they were probably in some form of compensated tamponade physiology. In other words, their preload and their afterload were balanced, along with how good their cardiac contractility was and their diastolic filling and all the other things that make the heart, you know, function properly, plus the pressure from the effusion surrounding their heart. And they were, I wouldn't say that they were stable before dialysis, but they were compensated. They were walking around, they could talk, they didn't have a lot of chest pain. And as soon as fluid started getting taken off during the process of dialysis, and we reduced their preload, now all of a sudden those filling pressures are changed, they're lower, and the patient was having a much harder time filling their ventricle and pumping out blood. So I'm not suggesting that every patient gets a cardiac ultrasound before dialysis, but I think that we need to be a little more cautious with patients that are tachycardic or borderline hypotensive, especially in patients that might be set up chronically to have effusions, pericardial effusions, and see how their heart is doing before we put a significant hemodynamic insult, which is taking all that preload off. So I just wanted to bring this case to light because it's the kind of thing that probably happens a bit more than we think. Think how often someone comes from dialysis because they had chest pain, because they had shortness of breath. Think how many times we see a patient that has some pericardial effusion, but they seem stable, and someone suggests that, well, we need to reduce their uremia by dialyzing them, and that will help take care of the effusion. Yeah, that will happen over the course of days, perhaps, that better uremia, or improving the uremia will increase or reduce the effusion. But minute by minute, all you're doing when you take off fluid is changing their preload, and that will have hemodynamic consequences before it has chemical and physiologic consequences. One other thing I just wanted to point out about this is there are some patients who have chronic effusions, some small, some large. And what you would expect to see with the inferior vena cava when someone has a large pericardial effusion is that there will be very little collapse. You'll have a plethoric inferior vena cava because of the backup of fluid into the inferior vena cava, into the venous system. In contrast, if someone has a flat IVC, it is almost impossible for them to have pericardial tamponade. And I think one of the guidelines that was written by the American Society for Echocardiography described that the negative predictive value for IVC plethora was 99% in the setting of pericardial tamponade. In other words, if you have a flat IVC, you don't have tamponade. So it's one of the many ways that you can check. There's many more subtle ways. And I think the point of this talk is not to go into some of the subtleties and the Doppler and all the other things that you can assess, and pulsus paradoxus and that sort of thing, but just the big picture of, we have a patient who's tachycardic and hypotensive, and we didn't put a probe on their chest early enough to see what their heart looked like. And that could have been very much more complicated for us. Any questions coming out of that?
No, I don't think we have any questions.
I have a comment, Brett, which it seems to me, it's always surprising that people have now learned, even as you say, pre-medical students have learned how to recognize this abnormality. And yet when they see it, they often resort to old-fashioned ways of draining the fluid without using ultrasound. And we've been talking about how to use ultrasound to access a vein, and people still, even who are quite expert at that, consider taking fluid off around the heart without using their ultrasound probe. So I wonder if you could just describe, after you saw this finding, what steps you take to actually take the fluid off using ultrasound guidance.
Yeah, that's a great question, and it is. You're right. There are people who do this all day long and still do it without ultrasound guidance, and it's a bit shocking to me. So there's been a lot. There've been a few big articles written about this, mostly observational, retrospective papers that are written by people who do this all the time. Cardiologists and other specialists who have done 1,000 of them, for example. And the common themes that I've seen in the literature are, look at the parasternal long axis view, look at the apical 4-chamber view, and look at the subxiphoid view, and see among those 3 views, where is the most accessible and the largest area of fluid that's collected. In some, because I think it varies a bit by the actual pocket of fluid, the actual pericardial effusion, the patient's body habitus, and some other factors. In general, I don't like the subxiphoid approach because it usually involves putting the needle through the patient's liver in order to reach the pericardium. There are other people who don't like, and I like the parasternal long approach for this because if I can visualize a safe amount of fluid and a safe amount of space, I can make sure that I'm far enough from the lateral sternal border to avoid the arteries and veins in that location. I can make sure that I'm above the ribs to avoid the veins and arteries in that location, beneath the rib. And I can hopefully avoid getting my needle so far down that I'm onto the heart itself, because no one wants to nick a coronary vessel, right? So, but there are some people who are so concerned about nicking a coronary vessel that they don't like the anterior approach. I like the concept that if there's enough fluid anteriorly and I can visualize the needle with direct guidance and get down into the pocket and stay off the heart, that I can place a catheter, a pigtail catheter, and get this drained pretty safely without having to go through a lot of soft tissue and without having to go through any other organs to get to it. Similarly, I don't love the apical approach because I am concerned that the patient could inhale deeply and bring their lung into, in the way. So, but again, all the articles that I've read that really describe a lot of cases talk about variation in how they approach it, and they might go apical, parasternal, or subxiphoid based on the largest amount of fluid. And I think that's the benefit of using ultrasound is you have your standard landmark-based approaches, and in that case, it would be a subxiphoid approach, but then you can alter it based on what you see with the ultrasound in real time.
Great, and I must say, I always put a catheter over a needle, and once I have the needle and the catheter in the pericardial space, I take the needle away so that as I drain fluid, I think it's much less likely the catheter could cause severe damage to any of the cardiac structures as the fluid gets drained. So that's personally my practice. I don't think there's any evidence for it, but to me, it makes sense to get the needle out of there as soon as I can. I don't know what you think about that.
Yeah, no, I agree. I think typically, I haven't had too many cases where there was such a crash nearly dead patient that needed a pericardiocentesis that we just went in with a needle, we do try to go in with a catheter, and now we stock the pigtail catheters in our department. So I think we have sort of three big picture approaches. If the patient loses pulses in front of us, we're probably going to put a needle in and just get in there and drain what we can until things stabilize. But even when the needle's in, you can put a wire through it and swap it out, as you mentioned, Anthony. The mid acuity approach, which is still pretty unstable, would be that we would place a pigtail catheter ourselves in the emergency department, and that catheter would remain in the patient's chest. And you're right, as soon as you get in, put it over the guide wire, you replace it with the pigtail catheter, and then that remains in the patient. And then the other option, which I'm perfectly fine with, because I don't need to be a hero for every patient every day, and there's other heroes that work in our hospital who are wonderful colleagues, is if I find a patient who's hypotensive and tachycardic and has a large pericardial effusion, and I'm concerned they have tamponade, I'll talk with my interventional cardiology colleagues, and they'll often just go down to the cath lab. And this is another thing to point out. There may be people on this call who haven't ever done this procedure, or maybe some who are very comfortable with it. Let me give you two different scenarios. I have a patient, hello, cardiology. I have a patient who's hypotensive and tachycardic. Why am I calling you? Well, maybe they have tamponade. What's the pulsus paradigm? I don't know. I didn't check that, but they're hypotensive and tachycardic, like 10% of my patients. I'm going to call you all day long, all the time, right? That's a weird conversation to have with somebody. Let's have the other conversation. Hey, cardiology, I'm worried about tamponade. Oh, why, you ask? Well, I see a large pericardial effusion in a patient with hypotension and tachycardia. Yeah, already the pretest probability is very high that this is, so can you come down and give me a hand with this? Okay, so that's a totally different conversation, even if you don't know much more than that. Even if you haven't done measurements, you haven't done Doppler, even if you're not comfortable looking and seeing like the right ventricle looks weird, it's bowing out, or it's coming in during diastole, which it shouldn't do. There's some nuance to some of that stuff. And even if you're new to cardiac echo, saying large pericardial effusion on my bedside echo in the setting of hypotension tachycardia, that's pretty serious. So if the cardiologist came down every time you said those things, they're going to have tamponade like half the time, 3/4 of the time, right? Whereas if every time you had a hypotensive tachycardic patient, you called them, it's going to be 1% of the time, and you guys are going to get mad at each other. So I find it's even, again, I wanted to go back to what I said in the beginning, even taking this in the simplest possible way. And I think we're all smarter than taking it in the simplest possible way. But even the simplest possible way, I think, is very helpful. And then your colleagues you either drain it together at the bedside, or they go to the cath lab. I don't mind that, as long as the patient's getting the care that they need. All right. If there's nothing else pressing, I'll move on to another case.
No.
Okay.
Let's go.
All right. Okay, so on the subject of waking people up at night, 64-year-old woman with hypertension, diabetes, lost the vision in her left eye about 2 hours ago. She had a very difficult examination. It was just hard to get a dilated exam on her. It was, she was having difficulty keeping her eye open. It was very difficult to visualize the retina on the affected side. It just sort of all looked a bit pink and blurry. So we were having a very challenging examination. So we placed a Tegaderm over her eye, or an opsite, or one of those little sticky plastic sheets. Placed a ton of gel on her eye, and we saw this. So made a diagnosis of retinal detachment, or at least a strong suspicion for retinal detachment, and spoke with ophthalmology, and again, had a very different kind of conversation. Now, ophthalmology often will be very glad to see patients, at least in my environment. We're very lucky that if someone has sudden onset of unilateral vision loss, like I think everyone agrees in my environment, that ophthalmology and emergency medicine, and depending on the exact case scenario, sometimes neurology considers that a bad emergency, would come and see the patient. But having a very strong suspicion for the retinal detachment is an even bigger deal. And being able to visualize the eyeball is a very satisfying thing to look at. There are so many things that are dependent on patient body habitus and how much subcutaneous tissue that they have, and a host of other things that being able to see the eyeball in its entirety is very helpful. So you can see the cornea, just deep to that is the lens, and the vitreous chamber behind that, the retina, which should be totally adherent on the back here and not separated, as we saw in that other image that we obtained on that patient. And then behind it, we can often see the optic nerve and the sheath behind it. So there's a lot of different pathology that you can potentially identify with the with ocular ultrasound. I would not recommend it if you're suspecting significant trauma to the eye, where you're thinking about a globe rupture, certainly, but there are some ways that we can visualize things like papilledema, retinal detachment, vitreous hemorrhage, etc., that can sometimes be challenging if you're not doing a slit lamp or ophthalmoscope all day long, as our ophthalmology colleagues are, and it can help move the patient forward a bit. So ophthalmology came in and set that patient up for a surgical procedure to see if they could tack down. I think it always involves lasers. And I have such respect for the people that know how to do stuff.
So I think we have gray box again,
Yeah.
but why you are closing it? So this is my questions. What is the difference between the appearance between the retinal detachment and vitreous hemorrhage? Because
Okay.
it seems like there is like jiggly things.
Yeah.
If you look at.
Yeah, it depends on where the jiggly things are, basically.
Okay.
So if this is the eyeball, typically retinal detachment is going to be a line that creates a second crescent shape on the edge along the back of the vitreous hemorrhage. I'm sorry, along the back of the vitreous, and it creates this extra little space around it. So like
Okay.
if you see a curved line around the back of the retina, that's typically going to be a retinal detachment, retinal hemorrhage. Vitreous hemorrhage is going to be in the center a bit more and looks smoky and moves as the patient moves their eyeball. So you could imagine it looks a little more. I think smoky is probably the best term for it. So
Yeah.
if there's the eyeball and there's smokiness, especially towards the center, and it moves as the patient moves their eyeball, that's more of a vitreous hemorrhage. And the retinal detachment is going to be more like the back of the eye
Layer,
is
the
here,
second layer.
the second layer, exactly.
Okay.
Yeah.
And
I think the other thing
let's
to
see.
say about the retinal detachment is that the retina actually is a continual membrane with the optic nerve. So even in the case I think you showed us, Brett, you can see that the detachment goes down and is tethered to the back of the eye where the optic nerve comes into the eye. The vitreous detachment often goes right across the optic nerve. So
Yeah.
you can see this one comes down here, and it's just at the edge of the optic nerve there, it joins the retina again. The retinal detachment cannot go across the optic nerve. So if it crosses over above the optic nerve, that thin line, then it's not a retinal detachment, it's a vitreous detachment.
That's a
I
great
don't know if
point.
you have any cases here to show that.
Probably not quick enough to pull up immediately. And I want to be very cognizant of everyone's time as we're getting into an hour and a half on here. So
We have a little bit of questions. This is actually a very common questions. Anna asked if have you ever had experience on measure optic nerve for intracranial pressure?
yes, since that's not the main point of what we're talking about today, I
Yeah.
would say this. My personal take on this is that if I have a patient that I'm concerned about elevated intracranial pressure, and I measure their optic nerve sheath diameter, and it is dilated, so greater than 5 or 6 centimeters, depending on which literature you like to read, I would try to expedite that patient's care, get them into CAT scan more rapidly, talk to neurosurgery or neurology, depending on what their issue is. I personally don't use it to rule out elevated intracranial pressure or to rule out other pathology. I don't know that there's enough literature for us to be able to do that safely. So I think you take a patient that you were considering getting a a CAT scan or a neurology evaluation or something, depending on what their pathology was, and it can potentially expedite their care if you see that it's dilated. But it doesn't take anybody, in my mind, it doesn't take anybody off the table that they wouldn't go to radiology.
Okay. Okay, no more questions.
Okay, so we're going to switch gears a little bit again here, and just talk about a very, very common application. Can you see my screen? Am I still sharing? I am.
Yes.
So there's a 47-year-old woman who's healthy, no other medical problems. She had right flank pain, and she had CVA tenderness and hematuria. Urine pregnancy test was negative. That's a really important thing to think about. And she was all set to get a CAT scan. And we had a look at her kidney and saw this. We saw dilatation and an expansion of her calyces, pushing out and distorting the internal anatomy of her kidney. We also saw here that her bladder was pretty full, and there was this little hyperechoic area that you can see in the bottom left of her bladder. So this was her her right side. So around the trigone of the bladder, at the base of the bladder, there was this hyperechoic area. And when we put some color on that, it speckled, and it had this multicolor little speckle coming down from it. Oh, and then we had this little red jet coming out towards us. So without, in her case, so this is really the comprehensive sort of renal colic evaluation that you can see. And we saw that, so we made a diagnosis in her case of a UVJ stone, and we could be so specific about it because we visualized the stone itself. Now, you don't often do that. It would be sufficient, according to many studies in the literature, including the STONE trial, STONE, that especially in a young, healthy person that has typical symptoms, when you see hydronephrosis, you've made the diagnosis of renal colic. We were able to get views where we could see the stone itself. And by visualizing that ureteral jet, we could actually see that she was not fully obstructed, but that there was some urine still passing from the ureter into the bladder. So, so then the next questions are really just clinical management questions. How is her pain? And that's probably the biggest factor that we need to look at. And then, you know, following up with urology. Urology is typically not going to change management emergently based on whether there's hydronephrosis or the stone size alone. You can measure the stone certainly on ultrasound almost as accurately as you could on CAT scan if you can visualize the stone. In many cases, you can't see the stone. But people sometimes use this threshold of, you know, greater or less than 5 millimeters for a stone. All that means is that a stone that's less than 5 millimeters has a more than 90 or 95% chance of passing, but that doesn't mean that a stone 6 or 7 millimeters won't pass. It's just that statistically the chances are less. So in my environment, at least, if a patient has a stone and their pain is under control and they're able to eat and drink and they're urinating okay, we can go home with some pain control, and they would follow up with urology. If their symptoms get worse, they would come back again. But it's rare that any emergent intervention would happen in a comfortable patient solely because of the size of their stone. Or whether they had hydronephrosis or not. So we use it mainly to make the diagnosis and establish the follow-up. And then we can,
Go ahead.
No,
so basically this is
hydronephrosis, and we want to make sure that we visualize the kidney in a transverse orientation as well as a longitudinal orientation for completeness.
So let me rephrase, not rephrase, but so the ureteric jet is a normal reflux. Is a normal thing. No.
Yeah. Yes. In a person with no stones, if you look at their bladder, you'll see their bladder filling up. So it's basically the ureteral jet is the fluid, is the urine coming from the ureters into the bladder, left side, right side. So we normally would see that. There are
sides.
Some, exactly. There are some people who would be concerned if you were suspicious for renal colic, if you can't see a jet on one side, then maybe there's a complete obstruction. And a complete obstruction is a little bit more concerning than a partial obstruction or no obstruction, right? So.
We have one question from Dr. Krongran from Chiang Mai. Would partial obstruction versus no obstruction have different ureteral jet characteristics?
In my mind, no. There could be. I don't know if anybody really, and I just don't know. I don't know if anybody really studies the flow characteristics and the nuances of ureteral jets the way that some of the most brilliant people in the world study, like aortic regurgitation, right? Because it's basically just, you know, there's so many factors, exactly how big the stone is, how far along the ureter it is caught. You know, there's so many things that would change that I've never heard of anybody using the characteristics of a ureteral jet to establish anything about what amount of obstruction there is. I think people typically just look at obstruction in terms of how dilated the calyces are, how much hydronephrosis there is.
Yeah. Thank you. No more questions.
Okay. So we just
so
have a couple more cases.
Yes.
So just let me check in here with Davide about our time here.
Yep.
Yes.
I see. So how do you think we should manage this, Davide? We're a little bit over time.
Are we, Davide?
Yeah.
Yes.
Should we continue, or are we okay to continue for a couple more cases?
Yeah. Yeah. Let's say in 10 minutes more. 10 minutes more for the attendees. I'm talking.
Okay.
Well, how about this, just to respect everyone's time? Why don't we do maybe one or two more cases and then a couple of minutes of questions, and then we'll be finished before this will be finished in the next 10 minutes. Does that sound reasonable?
Okay.
Okay.
Great. Because in Thailand it's almost 11 p.m. So.
Oh my goodness.
Yes.
Nobody should be staying awake for this. Let's
yes,
finish up then, so you
I
can
think
go to
we
sleep.
are very popular actually. People are actually staying up. You guys are
Okay.
like,
Okay, so do we have on the screen a 67-year-old male? Everyone sees this?
yes.
Okay, so this gentleman has unfortunately come to the emergency department many times. He has had multiple abdominal surgeries, multiple episodes of bowel obstruction. He has had hernia repairs and multiple different kinds of surgeries, but he's coming in with what he feels is his typical bowel obstruction symptoms: diffuse abdominal pain and tenderness, nausea, and vomiting. He has no fever. His laboratory examination looks normal, but I'll tell you that before his labs came back, we had already seen the ultrasound of his bowel. And some of the things that we saw were that we saw his bowel wall pretty well. And normally you don't see bowel wall very well. There's so much air in the bowel that the wall itself isn't very evident. So we see the bowel wall. We see that it's a bit dilated. It was greater than 2.5 centimeters. And we can see, especially in the middle here, that you could see that the peristalsis was going in one direction and then the other direction. So he had back and forth, to and fro peristalsis with some thickening of his bowel wall and some edema around the bowel wall. And here's another example that shows, you can see the peristalsis going to the right and then it goes to the left. So he had a bowel obstruction, and this might have been his first visit where he didn't get a CAT scan. And I think at some point when he was in the hospital, they did an X-ray, but you know, the decision was made with him, since his symptoms were pretty typical for him, since he didn't have any focal tenderness, and since he had been managed conservatively, meaning nothing by mouth, intravenous fluids, serial abdominal examinations in the past, that this gentleman wouldn't get what was becoming a weekly CAT scan. And you know, having a discussion with the surgical team and discussion with the patient about risks and benefits, this was one case that we actually managed with by using ultrasound instead of doing a CT scan, and we're able to make the diagnosis of a small bowel obstruction And I think this use is very interesting because the diagnosis of bowel obstruction can be made in a pretty accurate way. The sensitivity and specificity is in the mid 90s for this examination. I think the argument against using it instead of other studies is that it's often important to find if there's a transition point. That will sometimes determine if a patient is going to be a surgical candidate and to surgically manage their bowel obstruction versus managing it conservatively. So I think that whether you use ultrasound to expedite your cases, in other words, I'm worried about bowel obstruction and I see that there's to and fro motion, so I'm going to consult surgery earlier. And again, a different conversation. You don't call them every time someone has abdominal pain in the emergency department, right? But if someone has abdominal pain and prior surgeries and signs of obstruction on their ultrasound, that's maybe something that they would want to know about before several hours later when they eventually get their CAT scan, in time for them to drink the contrast and have it digest, et cetera. So, and then there may be other cases like this gentleman where we normally would get a CAT scan, but being reasonably familiar with his anatomy and the fact that the surgical team knew him and generally would try to manage him conservatively in general, this was a way to confirm the diagnosis and make us feel like we were on the right track. So again, this is a case where the individual management might vary with your institution, might vary with how comfortable your doctors are looking at ultrasound, how comfortable your surgeons are not relying on CAT scan or X-ray, but a way that I think we sped up the care for this particular gentleman.
We don't have any questions, so.
Okay. All right.
But
well, yes.
We are reaching the end of the, no,
Yes.
I was talking that we are reaching the end of the session. So you guys, if you have any question to ask Brett, now is a good time.
Yeah. And I'm also going to just make a quick reminder that anyone who wants to reach me forever, a week, a month, a year from now, can either visit my ultrasound website, sinai-em.us. There are tutorials and other information on that website if you're interested in learning more about ultrasound, or to reach me or my program at Mount Sinai. And again, I'm on Twitter at Brett P. Nelson. Oh,
we have one question from Tanya. Yes. So Tanya asks, how do you feel about the use of handheld ultrasound in ER? I'm guessing, Tanya, is it, do you mean handheld, like the small ultrasound?
I think I'm going to start answering as if that's what is meant by this. I think handheld ultrasound is fantastic. The benefits of it are that we can have very easy access to answer some of these simple questions and really expedite the care of our patients. We can make it accessible to a wider variety of people because the price on a handheld ultrasound system might be just several $1,000s, where the price on even the cheapest cart-based systems are at least 10 times that. And you know, if we can improve patient care and get more people using ultrasound appropriately, I'm a huge fan of that. There's a couple of downsides that we need to be aware of. One of them is we have to make sure that we are using ultrasound as a diagnostic tool the same way we use other diagnostic tools at our disposal. So we don't get an EKG on a patient and then look at it and throw it away. We don't get an X-ray on a patient and look at it and throw it away. Ultrasound technology for the last 15 years has been robust enough that you can save images, perform quality assurance on them, put the images into the medical record, share your findings with your colleagues. So I feel reasonably strongly that it's not just like a stethoscope. So I think that if you're considering using handheld ultrasound, you need to think through processes where the images are saved, they become part of the medical record, and that you can, you know, again, share findings and share medical decision-making with your colleagues. There may be environments where this isn't feasible, but it's an important consideration. And I wouldn't consider the fact that you use handheld ultrasound as an excuse or a shortcut to doing the kinds of studies that we're trained to do. But I love the idea of handheld ultrasound. Sutapon, you're muted.
Sorry. Tanya said, yes, the one that you plug in your phone, and she said, thank you so much.
Yeah.
And also, someone asked, hold on. I think someone asked if there is any way that she could get certificate for this webinar. Davide, this is your turn. Secretariat.
Two main messages for the attendees. The first one, if you want to watch again the webinar, you will find online in the WinFocus members area. If you are not a member, please join us for upcoming webinars. And yes, about the certificates, just write to us at secretariat.winfocus.org. I'm going to write all the details in the chat, and we will prepare the certificate for you.
Okay, no more questions.
All right. Well,
Tanya said thank you.
Yeah, thank you, Tanya. Thank you, everyone who asked questions. Thank you, everyone who joined us. Thank you to everyone around Asia and Thailand who were up late with us. I hope you sleep well and stay safe. Thank you for everyone for your passion, your questions. Thanks to our panelists. And thank you to WinFocus for putting this together. And most importantly, thank you to Suttaporn for being such an amazing host, for handling all the questions and guiding us through all this. It is a pleasure working with you. I've known you for a while, not too long. That would make us sound old. I've known you for long enough to know how passionate you are about ultrasound and education, and how you have brought this all around the world for helping people improve their care. So I can't thank you enough. Thank you so much.
Thank you. Thank you, Dr. Brett. I think everyone in the webinar said thank you. From Joseph. Arif said great webinar. Joseph said thank you. So, thank you again, team. And I'll let Anthony or Davide close this webinar. So everybody, Dr. Sakin also, thank you, Professor Brett.
Please, Anthony.
So Davide or Anthony.
Thanks to Brett. Thank you, Southporn, for the great webinar. And I'm going to give the speech to Anthony, who is the, let's say, the director of these webinars that we are putting together as WinFocus. So thank you very much to all of you, and especially to Anthony for creating these nice moments where we can share all of this.
I just thank you, Brett, for a great talk. Thank you, Suttaporn, for managing the show, and I hope everybody has had an excellent. I've learned an awful lot, and so thank you both for bringing all your thoughts to this. And please consider joining WinFocus, because as Davide says, all these webinars are free if you're a member, and there will be more. We're hoping to put on 2 a month coming up, so hopefully that'll be worthwhile. But thank you, Brett, and thank you, Suttaporn. Wonderful. Very nice.
Thank you. Bye-bye. Good night, everyone. Good morning, everyone. Good afternoon, everyone. Bye-bye.